right? Perfect. All right. So before we get into the stuff for today, quick question: How many of you, how many of you would be interested and or want to spend more time with me, potentially outside of class, uh, reviewing like the brachial plexus, the brachial plexus and the neuro exam? How many of you want to spend more time reviewing that? Because I'm happy to do it. Okay, it's pretty much everybody. Understood. Okay. Okay, or at least the majority of you. Not a problem. We'll make that work. Okay, because obviously this information is vitally important, so I want to make sure that we cover it and cover it well. All right, and then is that Bella back there? Or who do we have back there?
Just seeing.
Oh, cool. Okay. All right. Okay, friends. Here we go. So, doo doo. All right. Perfect. So we're going to cover quadrilateral space syndrome, thoracic outlet, and brachioplexopathies today. All right. Okay. Let's start off talking about quadrilateral space syndrome. First and foremost, we need to define what is the quadrilateral space. Okay. The quadrilateral space is an anatomical region, right? Um, with four borders, right? So if we take our hands and we put our hands right back behind kind of our tricep and our posterior delt, right deep to our posterior delt. Okay, we're gonna notice obviously our teres minor under there, and then our infra is going to be deep to the posterior delt, right? Well, right if you dip right underneath, okay, your teres minor, right close to the shaft of your humerus, you're going to feel a little dip there. And if you were to hold your finger there for a long enough period of time, you may even feel a little bit of pressure and or numbness right at your shoulder. Okay, that, friends, okay, is the quadrilateral space. You'll also notice that we also have the quadrangular space, which is right below it. We're not going to focus on that so much right now, but we're going to focus on the quadrilateral space. That's actually one of the most common neurovascular complications, even though it's more rare, right? In the shoulder. Okay, so what makes up the quadrilateral space? Okay, the superior border of the quadrilateral space is the teres minor. Okay, the inferior border is made up by the teres major, right? Medial border is the long head of the triceps, and then the lateral border is the humerus. Okay, so the reason why it's called the quadrilateral space, guys, is if you look at it, um, sorry, I just maximized on my screen. Can you guys still see?
Yeah.
We're good. Okay, good. And so you should see a picture of a shoulder with a yellow box.
Yep.
Perfect. Okay. So that, guys, if you look inside of that, you're gonna see like this little geometric shape, little quadrilateral, and that is called the quadrilateral space. Now, why is that important? The reason why that's important is this. Okay, is that we have the posterior branch of the axillary artery and the posterior humeral, posterior branch of the axillary nerve and the posterior humeral circumflex artery that pass through the quadrilateral space. Now, remember what we said yesterday, guys. We said yesterday that the axillary nerve, what muscle does it innervate? Who remembers? Who remembers what muscle does the axillary nerve innervate?
This is a guess. I don't know, the deltoid.
It's the deltoid, okay? And you can even see it in this picture, right? You can see that axillary nerve actually uh, kind of plugging in, right, or innervating that deltoid, right here on the lateral aspect of the humerus, okay? Um, cool. Now, here's the deal. Imagine, for example, all right, that we had maybe hypertrophy. Somebody that lifted a bunch of weight, and or maybe even a woman that's super fit, works out a lot, does a lot of body weight stuff, and maybe even lifts, right? And these individuals happen to have very, very strong and hypertrophied, either tricep musculature, and or like maybe even a really hypertrophied and large, maybe teres major, right? Really, really muscular people. Excuse me. If someone has a really, really, really hypertrophied muscle, what do you think will happen to the diameter of that space, the width of the space? Will the width of that space be more narrow, or will it widen?
Be narrow.
It'd be more narrow. What do you, okay, so if that space becomes more narrow, what do you think the consequences of narrowing of the quadrilateral space potentially would be? What kind of symptoms could somebody develop?
You're going to compress that nerve.
Okay, you're going to compress the nerve and even potentially the artery. Okay, so having said that, okay, quadrilateral space syndrome essentially involves compression of that posterior branch of the axillary nerve, right, and that posterior humeral circumflex artery, right, within the quadrilateral space. So when that happens, patients are going to start to have kind of this vague posterior shoulder pain, right? And they may also tell you that they've got, possible numbness and or pain at the posterior and lateral shoulder that also gets worse with abduction and external rotation. Okay. Okay. Why would their pain get worse with abduction and external rotation? Potentially.
Because that would contract those muscles and I guess compress them even more.
Okay. Yeah. So that it would cause the deltoid, cause the teres minor to contract, and obviously when those muscles contract, they're going to obviously shorten, uh, and that's going to actually decrease the area of the quadrilateral space. Okay. So believe it or not, right, this syndrome is actually most common in our younger patients, so 20 to 40, and honestly, even in people that actually do a lot of overhead motion, they may actually also notice this. Okay. So, what are some common clinical presentations or symptoms that we're going to see uh, in quadrilateral space syndrome? So let's say, for example, that nerve has been compressed for a long period of time. Okay, what do you think? What do you think if a nerve is compressed for a long period of time? What will happen ultimately to the muscle that it innervates?
It could start like tingling and seem like it's falling asleep.
Okay, yeah. So sensory deficit. What do you think will happen to the ability of that muscle to fire over time? Motor function probably will go down, right? So if the number of active motor units to a muscle goes down, do you think that we'll be able to adequately fire that muscle like we used to?
No.
Probably not, right? And so we're also going to notice some atrophy. Okay, atrophy at the posterior deltoid, coupled with symptoms of posterior pain and numbness. Those are key symptoms of quadrilateral space syndrome. Okay, so we can see that here in these pictures, right? Pain, obviously at the posterior shoulder, and obvious atrophy at the posterior deltoid. You can see how in the second picture, the deltoid almost kind of looks like it's flattened off entirely, almost kind of like the muscle girth is almost completely gone, right? Literally, it looks like you go from his humeral head, and then you just ultimately run into his tricep without any girth at the deltoid. Okay. Uh, Now, here's the other thing that ultimately happens when muscles atrophy, and we'll talk about this more when we talk about the rotator cuff as well. The one thing that happens to muscle over time, right, when it atrophies, is that if the muscle atrophies and it's no longer being used, the muscle tissue actually gets infiltrated with fat. Okay, and so if the muscle tissue gets infiltrated with fat, it obviously becomes less viable. Okay, it becomes less viable, and the muscle itself, when we talk about rotator cuff repairs, you will not be able to utilize or basically appropriately stretch a rotator cuff muscle that has fatty infiltration to be able to repair a rotator cuff tear, right? Because the muscle has lost its elastic properties and will likely just tear, right? Okay, check it out. So here's the effects on the vasculature. okay, on the vasculature of the posterior humeral circumflex artery, right, in different positions. So you can see, pardon me, okay, you can see actually um, on basically ultrasound here on the left, okay, there's a yellow arrow demarcating the posterior humeral circumflex artery, and then the axillary nerve. Um, Now you can see, okay, that in a normal position, right, and this is we're looking at the bottom ultrasound picture here. Okay, when this person's in neutral, you're going to see that bright red orange.
Wait, I don't think we could see the ultrasound.
Like
At
you
least I
can't.
can't.
Okay, you can't see it. Okay,
Still see the shoulder with the yellow box.
weird, man. That's freaking awkward. I'm sorry. Okay. Um. Damn. How does that happen? Okay, hang on. Let me reshare. All right. A window. All right. Do you see that again? Show the shoulder with the yellow box.
Yep.
Okay. I have moved slides. Do you see the next slide?
I do not. I don't know about anybody else.
Damn it. Okay. Sorry for cussing. Ugh.
There it goes. With pathologies you're on.
Okay. Okay. So it obviously doesn't like it when I'm in full screen. There you go. Figured it out. Okay. What about now?
You're good.
I can see pathophys. Yep. Okay.
Perfect. Okay. So guys, obviously what I was just talking about. Okay. I want you to be able to see the slides. Freaking Google Meets, man. Gotta love it. Sorry, folks. Okay. So quadrilateral space, right? The patient's going to present with posterior shoulder pain, potential numbness, right, at the posterior and lateral shoulder. Pain's typically going to get worse with abduction and external rotation, right, and potentially noted atrophy and wasting of the deltoid muscle, right? Most common in patients between the ages of 20 and 40, and also obviously with patterns of repetitive overhead motion. Okay. Okay. So here's the deal, guys. Here's what atrophy of the deltoid looks like. All right. I'm sorry that you couldn't see this, but okay. Ultimately, we know that when a nerve is compressed for a long period of time, okay, when it's compressed for a long period of time, ultimately the muscle, okay, begins to atrophy or can begin to atrophy. Now, and you can see pictures of that here. Okay, in Figure 1, we see this individual, okay, with noted atrophy to the posterior deltoid. Okay, and then the picture next to it, same thing. Okay, you can see the obvious flattening of the deltoid and loss of girth. Okay. Now, like we just kind of mentioned, the one thing that happens to a muscle when it atrophies is that the muscle actually fills in with fat with fat. Okay, and it makes the muscle itself less viable. So, an example that we gave, right, with a rotator cuff repair, is that when the muscle has a higher level of fat infiltration, that it makes the muscle less elastic, right? So in a rotator cuff muscle that has a lot of fatty infiltration, we won't be able to sufficiently pull it or stretch it to be able to repair a rotator cuff tendon that's torn, right? So that can ultimately result in a rotator cuff that's not repairable. Okay, back to this. So you guys can see here, okay, on the left, okay, the black boxes, we have pictures of a diagnostic ultrasound. On the right, okay, we have pictures of a CT angiogram. So on the left, the boxes with the diagnostic ultrasound, we can see that the nerve is circled there with the capital N above it with an arrow pointing to the axillary nerve. And then right next to it, okay, we're going to see another little arrow with the letters PCA. And that's posterior circumflex artery. Okay. Now, the one thing you'll notice when we turn on, obviously, our color Doppler down at the bottom, okay, you're going to notice on the right-hand side, okay, the nerve. But then when the shoulder's in neutral, okay, you notice that the blood flow stays, okay, in the posterior circumflex artery, right? And ultimately, what you see then on the right is when that shoulder is actually abducted, okay, and externally rotated, you can actually see that we're actually closing down the artery, right? And the blood has actually almost kind of spread out into the muscle tissue. And I'll actually be able to demonstrate that for you guys. Hopefully we'll be able, when we explore the bicep and the labrum, we are actually going to utilize our diagnostic ultrasound that we've got. And I'm actually going to show you guys what that looks like on ultrasound, right? Super cool. It'll blow your mind, right? And I'll show you guys exactly what this looks like. Okay, so here's the other thing. All right. Sorry. So with an angiogram, okay, here it is in neutral, and you can actually see, okay, you can actually see that with the with the angiogram, okay, this is first and foremost letter A, okay, the right arm, it's in neutral, and you can see how the dark areas are blood that's essentially kind of filling in the arteries, okay, but however, okay, when we abduct and externally rotate, that blood is essentially shunted out of the artery into the tributary, right, of the posterior circumflex artery, and blood flow is actually impeded, right, uh, from the axillary artery back there. Okay, do you guys see that? So that's why abduction and external rotation causes a problem, because it actually constricts the arterial blood supply. Okay, am I making sense?
Yeah.
Okay, if I'm not, stop me. Okay, tell me if I'm not. Okay, how do we treat quadrilateral space syndrome, right? So ultimately, we diagnose quadrilateral space syndrome with ultrasound or MRI, right? And there are also times where we can do a confirmatory EMG, right, to essentially look at nerve conduction velocity of the axillary nerve, right? So we can attempt to treat it conservatively, right? Because right now surgery for quadrilateral space syndrome is not necessarily all that successful. So we can try basically stretching into adduction and internal rotation. So basically sleeper stretches, right? Mobilization of our glenohumeral joint, and so basically just a lot of scapular, uh, stabilization, and also massage, soft tissue work, right? And then obviously working on shoulder strengthening. So really, obviously trying to lengthen tissue and open up the quadrilateral space. So obviously, if we have treatment that fails, if we're not successful with stretching, we're not successful with manual therapy, with rehab, we can attempt to do an injection of lidocaine or maybe even a steroid into the quadrilateral space to calm down that nerve, okay, and hopefully decrease the inflammation. Okay. All right. So let's talk real quick about causes of compression, right? So this can be anything from obviously trauma. Nerves can be compressed by trauma because the tissue around the nerve essentially starts to swell, right, and retain fluid. So trauma or acute injury. Oftentimes we can also have these things called paralabral cysts that can pop up. So if we have a labral tear, right, ultimately we can get an outpouching in the glenohumeral ligaments and develop a cyst secondary to a labral tear. Okay, we can have a bone spur on the humerus of a scapula that can cause compression. What the what? Sorry, folks, I'm not really sure what's going on. My screen just went crazy. Okay, bone spurs. Okay, muscle hypertrophy. So like we talked about, those people that are really, just kind of big, bulky people that like to lift a lot, right? So hypertrophy of muscles can actually cause neurocompression. Okay, now a couple other things that are a little less intuitive. Sometimes if somebody has an upper extremity DVT, a little bit less, that's a lot more rare actually, but that can actually also cause neurocompression, right? And then there are also times where we have a nerve that, responds to stress, excuse me, it responds to, constant sliding in and out of the epineurium, right? Due to motion, the nerve responds by actually getting bigger. Okay, nerves can actually hypertrophy and get and become larger in diameter. And so sometimes if a nerve becomes larger in diameter, that can actually cause compression too, because the nerve is actually become larger and filled the space. Okay, and so there's less space between the surrounding musculature and the nerve itself. All right, moving on to thoracic outlet syndrome. Okay, so thoracic outlet syndrome, also abbreviated TOS. So thoracic outlet, right? This is an anatomical region, right? And so this actually encompasses, words are hard, an area from the supraclavicular fossa, so right above our clavicle, okay, all the way into the armpit or the axilla. Okay, so now here's the thing. Okay, there are various sites of compression that we have, okay, that we can actually kind of deal or essentially see with thoracic outlet syndrome. Okay, first and foremost, and this is actually one of the most common, okay, is the interscalene triangle. So that's actually a group of muscles that are deep to your sternocleidomastoid in your neck. All right, and as those nerves and vasculature exit above, right, the clavicle, and then make their deep dive below the clavicle into the arm, right, they can actually become compressed by the scalene musculature. All right, they can also become compressed at the space between the clavicle, right, and the second rib. Okay, so clavicle and second rib, you can actually feel that. So if you walk your fingers over to about the middle of your clavicle, and then you drop your fingers right down, you're going to actually feel basically the anterior portion of your second rib right below your finger, right? So the space right above that is your costoclavicular space. Okay, you can have compression of the obviously of the artery there, right? And then also at the brachial plexus, obviously at the coracoid. Okay. All right. Okay. Here's the thing, guys. There are different types, and I'm going to kind of pick up the pace a little bit. I mean, we're fine, but I'm going to kind of go a little faster. So there are different types of thoracic outlet syndrome. Okay. There's neurogenic, arterial, and venous, and then there is actually a type of thoracic outlet that is actually atraumatic, right? It's actually of insidious onset. So neurogenic, okay? Neurogenic thoracic outlet syndrome, okay, is compression of the brachial plexus, either under the scalene's costoclavicular space or subcoracoid space, okay? So a lot of times when people have neurogenic thoracic outlet, symptoms will actually travel into the arm and hand. They may feel numbness, tingling, right, into the hand or fingers. Now, really important though, to rule out other pathologies as well, right? So we need to know that the symptoms into the arm and hand are not caused by like a cervical disc herniation and or Facet syndrome, right? And then very often, the other thing that we'll often do in our diagnostic process is there are times where we will also do a scalene block, which is essentially injection of anesthetic, okay, onto the brachial plexus, like around the scalenes, right, to be able to essentially confirm that the compression is actually happening at the scalenes, right? So if we do a scalene block and people get better, right, that's actually indicative of true neurogenic thoracic outlet. But for example, okay, and as we talked about with the hip, this is another example of something that is both diagnostic and therapeutic. Okay, who can tell me if you remember what both diagnostic and therapeutic means? So if it's diagnostic and therapeutic, what does that mean?
Isn't diagnostic like imaging?
Okay.
Maybe not. I don't know. But then therapeutic is like for rehab or like,
Okay.
I don't know. Maybe not.
Okay. No, Bennett. You know, that was a good try. Okay. So if we remember, sorry, I didn't mean for that to sound snarky, but with what I mean when I say this is this. Okay. If we do the block and people get better, that's how we know. So it's diagnostic when that tells us that we got our diagnosis correct. So it's diagnostic of thoracic outlet because someone got better with the treatment, right? And so it's diagnostic. We know that our diagnosis is correct because the treatment worked. So we confirm our diagnosis. Okay, it's also therapeutic because the person got better with the treatment. So the treatment itself is both diagnostic and therapeutic. Okay, we see the same thing with hip injections and lower back injections as well. Okay, all right. So that's what I mean when I say that. Okay, arterial compression. Okay, so here's the deal. Okay, this is essentially caused by compression at the subclavian artery. All right. Now we will ultimately to confirm this diagnosis, we will notice changes in pulses. Okay, and there are specific special tests that we'll see in the next few slides. Okay, that are actually going to help us confirm that diagnosis. So there'll be changes in pulses with the arms elevated, right? And potential discoloration, skin lesions, okay? Sensations of essentially uh, coldness and or like, uh, even maybe even a presentation of the arm feeling pale, okay? Actually, same thing with our venous presentations. Venous presentations, however, are also more likely to present, um, pardon me, are also more likely to present with edema, okay? Now, atraumatic, excuse me, okay, atraumatic venous thoracic outlet is referred to as Paget von Schroeder syndrome. Okay, Paget von Schroeder syndrome is a venous thoracic outlet, right? That shows up, right, without any injury noted, right? So if you're talking to the patient, they're not going to tell you, yeah, this happened, or I'm a volleyball player, I'm a swimmer, what have you, and I've been noticing these symptoms for weeks, for months, right? This person will typically come in with a very kind of swollen and puffy upper extremity, right, without any notable cause. The one thing that you may also notice here is distension or engorgement of neck veins. Okay, and symptoms can get worse either at rest or with the arms overhead. Now, here's the deal: the one thing that if you see this, if someone comes into you with an atraumatic like Paget von Schroeder syndrome that looks like this, the one thing that you need that would be really pertinent and appropriate for you to do is to refer this person for upper extremity either Doppler and or imaging to rule out an upper extremity DVT. Okay, always rule out your DVT before you just assume that this is just Paget von Schroeder. Okay, do a really, really good neurovascular exam, check your pulses, okay, radial, ulnar, brachial, make sure that they're symmetric bilaterally. Okay. Any questions so far? Okay. So, clinical presentation of thoracic outlet, right? Patients are generally going to complain of symptoms with the arm either at the side or above the head, right? So there can be pain in either position. Now, if it's neurogenic, right? These people may feel symptoms all the way into the hand. Okay, they may feel tingling, numbness, burning, right, and maybe even a feeling of tightness or swelling. There may be feelings of kind of coldness in the involved extremity, with maybe even some pallor, or like a kind of a pale appearance. They may even complain of things like weakness into the hand. Okay, so essentially deficits in motor function. All right, what are some special tests that we can utilize? Okay, for thoracic outlet. Sorry, I'm kind of zipping through this, but okay, let's go back to this slide. Okay, one of the first ones. Okay, this is the elevated arm stress test, also called Ruse test. Okay, uh, so it's the abbreviation here is the EAST test or Ruse test. So this is where the patient actually will go ahead and lift the hands, and they'll kind of wave. Right, they're going to kind of wave, and they're going to do this for approximately 3 minutes. Okay, and what we're looking for here. Okay, what we're looking for is return or reproduction of symptoms, numbness, tingling, or pain with the arms in this position. Okay. Conversely, right, if we're looking at essentially neurogenic thoracic outlet, um, so we're going to use basically the upper limb tension test to try to assess for these symptoms. Okay, so you can see here um, that obviously in position A, right, the person is simply abducting the shoulder, but okay, if the patient ultimately extends the wrist and keeps the elbow straight, um, that this ultimately could be obviously indicative of either carpal tunnel, right, or neurologic symptoms with the wrist extended. Ultimately, though, if the patient flexes the elbow, that could indicate cubital tunnel. So ultimately, utilizing the upper limb tension test is going to essentially help us kind of essentially differentiate between other peripheral neuropathies like cubital tunnel and or carpal tunnel versus neurogenic thoracic outlet. Okay, here we go, guys. So in someone that has potential vascular cause, okay, we're going to use 3 different types of tests here. All right, so we have Allen's test first, okay? And one thing you're going to notice with all of these tests, the examiner is always checking a radial pulse, okay? So Allen's test first. Excuse me, the examiner is going to stand behind the patient with the fingers on the radial artery, okay? They're going to have the patient turn their head away from the involved side, take a deep breath and hold it. What the examiner is looking for here, right, is for the pulse to essentially diminish or disappear, right? If that happens, okay, that is known as a positive Allen's test. Okay, first one is Allen's test. So remember, Allen's test, head away. Okay, Allen's test, head away to the opposite side. So Adson's test. Okay, Adson's is when obviously the examiner is standing behind the patient, checking the radial pulse again. All right, but this time the head is turned toward the involved side. Okay, so Allen's test, the head is away. Adson's test, the head is towards. So the head is turned toward the involved side. Okay, the examiner is taking radial pulse, has the patient inhale and take a deep breath and hold it. Okay, looking for that obviously diminished or disappearing radial pulse. Okay, and then the last one that we see here is the military brace test. So the examiner is going to essentially take the arm again, but the one thing you notice with military brace is the head position. The patient simply looks up to the ceiling and extends the cervical spine. Military brace, okay, the examiner is standing behind the patient and extending the shoulder. You see how the shoulder in this test is essentially passively being extended. Okay, so the examiner is going to have the patient take a deep breath and hold it, and the examiner is going to look for a diminished or absent radial pulse. Okay. Any questions about those? And we are going to work on those in class, so don't worry. Okay. Any questions about that? Big fat no? Okay. All right, friends. Last set of pathologies, only like 4 more slides. Okay. So Brachioplexopathies. We still doing okay? Okay. Okay. And you guys can see the slides without a problem?
Yeah.
Perf. Okay, awesome. Okay, so brachioplexopathies, guys. Okay, these are our brachioplexopathies, right? These are going to be our traumatic injuries, but we also have a subset that we're going to learn about, right? That's also atraumatic. So, if you guys, how many of you guys have ever heard of the term and or probably even had what people call a stinger or a burner? You guys have heard of that? Got it. How many of you have actually had a stinger or a burner? Anybody? Is that a yes? For anyone who's ever had one, Drew, have you ever had one as a football player? Where'd Drew go?
No, sorry, my unmute button wasn't working.
You're good.
Nope.
You're good. Okay. So ultimately, right, particularly when you spend time with football, right, people, you're gonna hear this term. People are gonna tell you that they have either a stinger or a burner, right? It's like, oh, I mean, I got a stinger. My arm feels numb, my fingers feel tingly. Okay. So ultimately, those are common terms or colloquial terms that refer to brachioplexopathies. Okay. So they can be traumatic. Okay, and can be either traction based or compression based. Okay, they can be atraumatic, and we'll talk about that. And then iatrogenic, right? Iatrogenic means that they're caused by a healthcare provider. Okay, so there are actually situations in which, pardon me, there are situations in which, um, sometimes during a procedure, like maybe a neck surgery with a front approach, um, you can actually have a little bit of damage to the brachial plexus because the provider maybe didn't sufficiently protect the nerves during the procedure, or maybe during an injection, the provider actually nicked the needle with a nerve, right? So those are examples of iatrogenic or nicked the nerve with a needle. Sorry. So those are actual examples of iatrogenic causes. Okay. Okay. So how do we understand or break these pathologies down? So ultimately, with traumatic brachioplexopathies, okay, traumatic brachioplexopathies occur either, okay, and I wish you guys could see me because I should have put this on the slide, but ultimately these occur via either compression, where the head gets essentially forcefully side bent toward the shoulder, okay, and the brachial plexus is compressed between the neck and the arm, okay. So you get the head gets forced to the side, and the brachial plexus gets compressed between the neck and the shoulder, okay. Conversely, a traction injury, okay, is where maybe you fall or somebody makes contact and your head gets forcefully pushed away from your shoulder and the brachial plexus becomes stretched. All right. So when we talk about traumatic brachioplexopathies, okay, either compression injuries or traction injuries, there are three levels of severity, from least severe to most severe. Okay, the least severe is called neuropraxia. Okay, neuropraxia is just essentially a temporary essentially injury and or compression to the brachial plexus, and the symptoms of neuropraxia typically resolve within, you know, uh, only within hours, within minutes to hours, or within, just a few days to a month. Okay, so these symptoms are typically resolving, uh, and we'll resolve at most within a few weeks. Okay, exontomesis. Okay, now this is actually more severe, and this is actually where there's actual stretching of the nerve and damage to the axon. Um, and you may notice, obviously, with axontomesis, the more permanent neurological damage. So someone may take a lot longer to regain sensory function, right? And or motor function to the arm and hand after exontomesis. Now, the one thing that I'll tell you is that in someone even with symptoms of neuropraxia that are lasting, more than maybe a week or so, a couple weeks, most providers, and this would even be prudent for you as an athletic trainer, if you have a patient who has lasting symptoms past a week or two, um, you may want to talk with your physician about getting this individual an EMG. Okay, you may want to go ahead and just do an EMG. The reason for that being is you want to cover your butt, right, and make sure that you're not missing any permanent damage to the nerve of the axon, right. So the bottom line is that if they're not getting better past a week or two, go ahead and get them over to your doctor and go ahead and just try to get them in for an EMG. All right. So the bottom line though is that neuropraxia, the symptoms will resolve typically within a few weeks. With axontomesis, you may have some lasting symptoms, okay, either sensory or motor, right? But then with neurotmesis, which is the most severe, this typically involves avulsion or complete tearing of the nerve root or the axon, and that can result in permanent damage. Okay, permanent neurological deficit or damage. For example, let's say someone has permanent like neurotmesis to the C5 nerve root, okay, after a brachial plexus injury. They may never again be able to set the deltoid or abduct the shoulder. Okay, does that make sense? They may lose that function completely, and they have to undergo maybe some sort of nerve grafting surgery to maybe recover some function. Okay, so neuropraxia, least severe, axontomesis. Okay, moderately severe, and then neurotmesis is most severe. Okay, and the bottom line is that we are looking for deficit. Does the deficit resolve, or is the deficit permanent and lasting? Right? Does that make sense to everyone? Okay. Sorry, you guys good? Or did I?
Yeah.
Okay, do I need to stay on this slide for a second?
No, you're good. It's just a lot of information.
I know, guys. Yeah, this is what, like I said, like the stuff that we're covering right now, this is some of the hardest stuff we'll do all semester. All right. And we're going to figure out ways to kind of carve out time where we spend more time on this. All right. So please don't worry about it. We're going to figure out a way to make sure that we're spending time. Okay.
Perfect.
So don't worry. Okay. All right. Next slide. So here's the deal. Okay. Brachioplexopathies. Okay. There is a subset of brachioplexopathies that are atraumatic. Okay. So we talked about, remember guys, how we talked about just a minute ago that, there are times where with nerve compression, it can actually be due to the fact that the nerve itself was actually increased in diameter, right? In response to stress, in response to longitudinal stress. So the nerve actually kind of increases its diameter, right? That's called idiopathic neuralgic myotrophy. Okay, so that's an increase in diameter of the nerve. Okay, I'll give you guys a minute to write that down. So you can just put down increased diameter of the nerve due to longitudinal stress. Okay. Increased diameter of the nerve due to longitudinal stress. Okay. So conversely, right? There's also another pretty common cause of atraumatic brachioplexopathy known as Parsonage-Turner syndrome. Okay, Parsonage-Turner syndrome are symptoms of brachioplexus pathology that occur generally at the same time as a viral illness. So Parsonage-Turner syndrome can occur secondary to a viral infection. Okay, so if you see brachioplexus symptoms kind of in concert with basically a viral illness, this is called Parsonage-Turner syndrome. Okay. Okay, so obviously with our atraumatic causes, right, there is no injury or trauma. They're not going to have a mechanism they're going to tell you, but there's obviously going to be severe pain, numbness, weakness, and maybe even a little bit of partial paralysis, inability to move the arm. Okay, but these are generally resolving. Sorry, they generally get better over time. All right. Okay, you guys ready? Next slide.
Yeah.
Cool. All right, guys. Here's the other thing. So obviously, like we talked about, we can also have iatrogenic causes, which means that as a healthcare provider, our treatment actually caused the issue, right? So radiation therapy. Sometimes we can see problems with positioning during surgery, right? Complications due to surgery, injections or procedures, and then chemotherapy. Okay. Sometimes these can actually have an effect on nerves. Okay. So that's the last slide. I'll let you guys kind of take notes and write. Any questions, guys? I mean, I know that this was a lot of information, and like I said, guys, this is up there as far as a level of difficulty. This is pretty much one of the most difficult things we're going to learn all semester long. So it gets a little easier after this. Okay, but like I said, I'm going to find the time to make sure that we're going over this so that we can teach it effectively. Any questions over anything that we've talked about? Okay. Well, guys, we'll spend more time in class going over the plexus, reviewing our exam. So we're going to get into the biceps and labrum next week, but we'll carve out time in class to go over this. I have a question for you guys real fast. I know it's time. How would you guys potentially feel to kind of open up some room next week to continue to work on this a little bit? If I went ahead and just recorded the lecture material for next week ahead of time, and just let you watch it, so that we're not lecturing and we can devote a lot more time to just practicing the skills, would you watch the lectures?
Yeah.
Yeah.
That's a yes? Okay. So what I'll do then for our biceps and labrum stuff next week, I'll post the lectures, and we won't necessarily go over it like during class time, but we're going to spend a lot of our time then next week literally working on brachioplexus, neuro exam, and special tests. Okay, that's what we're going to work on next week, is all exam stuff. Okay, does that make
Yep.
sense to everyone?
Yes.
Cool deal. All right. Hey, I will see you guys Monday. Have a safe weekend. Okay, you guys rock my socks off. Okay,
Bye, Wade.
see you Monday. Bye, guys.
Yeah.
Bye. See ya.
Hi, Wade.